Oftentimes in rural areas, or especially frontier areas, the emergency function of physician function is handled through an on-call arrangement. So the doc might be at home or wherever. In our case, we're afforded the luxury of having ER physicians in-house ready for whatever walks in the door.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals.
We're heading to the Midwest today to Albany, Missouri with Jon Doolittle, President of Mosaic Medical Center. Welcome to the Business of Healthcare podcast, Jon.
Thank you, Bob. Happy to be with you.
You know, Jon, I hail from the Midwest also. And if we had a bumper sticker for the Midwest, it would probably say, it's no big deal. It's kind of the way we think in the Midwest like that. And, you know, today for our audience, we're going to talk about rural hospitals. And that's an important topic. And in order to get the scene set for this type of discussion, I'd like to have you share a little bit more information about where you are. People don't know where Albany, Missouri is, but I know it's about 100 miles north of Kansas City. And I know that if you were to Google Mosaic Medical Center, you would see a picture of your facility. And there's also a little video of you for 1 minute talking about Albany. And I was taken back because it said very clearly, I'm an Albany kid and I was born in this hospital. And the character of the people here, that's what it's all about. It's an investment, extraordinary primary care. So kind of build on that for us, Jon. Tell us the story of how you came from Albany off to an education in the East Coast at Harvard, and then into the medical profession, and now back as the president of this hospital where you were born.
Sure, Bob. I was born here, November 1974, and grew up in Albany, Missouri, a town of about 2,000 people. Was blessed to be surrounded by an incredible community, great local school, and got the opportunity then to go back east, get an undergraduate degree from Harvard. And the whole time I was there contemplating next step, I thought a lot about getting close to home again. Northwest Missouri has tremendous attraction for me. My family and friends are here. I love the quality of life. And so the obvious step for me was to move back to the area. I landed in Kansas City, Missouri, went to work for the Federal Reserve Bank for a short time. My first boss at the Fed went to a company called Cerner Corporation, which later became a huge health information systems company. He recruited me to come help him as Cerner was going through boom years in the early 2000s. And throughout my time at Cerner, almost 12 years there, I kept moving closer and closer to the actual delivery side of healthcare, managing nurses, managing teams that were working on corporate healthcare, wellness. We started an on-site clinic, did integration with local daycare center, did a lot of really fun things at Cerner. And all of those things kind of helped me continue down a path toward returning home to my little hometown of a couple thousand people in Albany. That small rural hospital where I was born was flourishing. It was an independent hospital at that point called Northwest Medical Center. And the local board of directors hired me to come back. I came back in July of 2010, took over from a man named John Richmond, who was in the present CEO role for almost 30 years, a great steward of this organization. And I got to go to work. And through the 11 years that I've been in this role, we made a decision that our best future would be as part of something larger. And we had a great partner in the region, Mosaic Life Care, based in St. Joseph, Missouri. In 2014, the board of trustees of Mosaic and the board of what was then Northwest Medical Center decided to embark on a great partnership so that the hospital in Albany could become part of a larger system. And the great thing about that is we did this partnership agreement. We didn't know for sure what the future of healthcare delivery would bring. But what we said in the contractual agreement was that we wanted to build an exemplar site for rural life care. And we have had a great time over the last 7 years. figuring out what that means and constructing programs and relationships and culture that have really allowed us to, I think, be an extraordinary critical access hospital, a little rural health system associated with something larger in St. Joseph as Mosaic Life Care. And we're doing our best to show how well rural life care and rural health care can work.
Okay, well, Jon, that's a great story. I love hearing that. It speaks a lot to the character of Mosaic and to your own character as well. I know this. You've been there 10 years as the president, so you know the ins and outs of the rural hospital. And, today I want to try to explore that. I want people to get an education here about the importance and the functionality of the rural environment and how important and critical it is going forward. And at the same time, I want to get a little bit, just a general understanding of what a rural hospital can do and can't do. If you remember the Forrest Gump movie, one of Forrest's work partners in the Army was in the shrimping business. His name was Bubba. And Bubba went through a repertoire of describing all the different types of shrimp that exist. And it's quite comical. And I kind of looked at up the history on hospitals and the kind of hospitals. And it kind of sounds like that Bubba shrimp story. There's academic, acute, ambulatory, children's, clinics, community, district, federal, for-profit, free, general service, on and on and on, all the way down to the letter V, almost A to Z, the Veterans Hospital. That's a lot of different types of hospitals. Tell us specifically, what would you define a rural hospital to be?
So a rural hospital is located in an area that is designated as a rural area, by the federal government, serves in a region that tends to be sparsely populated. There are different flavors even of rural hospitals in this country, and Mosaic Medical Center Albany is actually something called a critical access hospital. Nearly a quarter of the hospitals in this country, acute care hospitals in this country, are critical access hospitals. And that's a designation that came about 25 years ago. It has to do with the types of services we are designed to offer in rural areas. And the size of the hospital, we're limited to operating 25 acute care beds. And we get some preferential reimbursement from Medicare and Medicaid. They pay us when we serve their beneficiaries on a cost basis because they know that we need to have tremendous capability and availability of services, and yet we don't have the volumes that would normally make us as cost effective or efficient in that manner. And so we are afforded some special reimbursement and some different regulatory environment in order to be able to have very high levels of capability available to folks who live in sparsely populated areas.
Okay, so when you use the word acute care, in my mind, I think of short-term needs. Is that correct?
Yeah, so can be. Of course, you also have long-term acute care facilities that are dealing with folks that have a significant medical need and are going to have a longer duration of their stay. And then within critical access hospitals, there are often three types of uses for perhaps even the same hospital bed, the same ward, the same wing. In our case, we do provide acute care services. So that would be, a sick care stay, usually shorter duration. That same bed, that same doctor, that same nurse, that same staff, equipment, therapist can be used to provide swing bed services, which are a post-acute designation. So it wouldn't be uncommon for us, say a patient has an accident. They come into our emergency department and they're in need of some significant orthopedic surgery and treatment. They might be transferred out of our rural facility to a specialized facility and receive surgical services and other very intense services. And then when it's time for them to be done there, they're not quite ready to go home. They could be transferred back to our hospital and stay for a period of time when they have a skilled care need, therapy, IV medications, other sorts of things, and be in a very high quality care setting. We also, of course, have observation stays, which is technically an outpatient service. But again, somebody comes in, needs to be observed in a hospital type environment to figure out whether or not they need an acute care service or can move on to something else. And we do all of those things literally in the same room, same bed, same nurse, same doc, providing a variety of care options to a sparsely populated rural area.
When I first heard the term swing bed, I really didn't have a clue what it meant. but now I do. It's an established process to allow patients to get the right level of care that they need for most critical care, then come back to an environment where they can get continued quality care in a rural community where the attention might be better than that of a larger, busier, industrial type large hospital.
Yeah, whether the quality of care is different, folks are afforded the opportunity to recover closer to home, closer to friends and family. They often are familiar to our staff and to our doctors. And since a lot of their care originated here, it's really a great way to close the loop on the continuum of care. And they can receive very highly specialized and attuned discharge planning and life planning for how they're going to succeed after they no longer have that skilled need.
So I've heard hospitals categorized sort of like clothing, small, medium, and large. A small hospital is less than 100 beds. I don't know if that means critical care beds or what kind of bed. And then a medium-sized hospital is up to 500, 100 to 500. Then greater than that, 500 would be a large hospital. Is there such thing as a large rural hospital?
No, not usually. Perhaps there's someone out there that knows of one. There are areas where hospital needs are consolidated across a large geographic area, or perhaps a hospital that formerly was rural has become much less so due to urban and suburban sprawl or something like that. So there are rural hospitals and critical access hospitals that find themselves in much more densely populated areas because of demographic change, growth in suburbs, those sorts of things. And there are critical access hospitals that supply a very high level of care. In our case, we truly are rural, not quite frontier, but we are the hospital for a 2-county area that's, would take 50 miles from the south end to the north end of our area, and yet only about 9,000 folks live there. And so our partnerships with the ambulance district, with clinics across the various towns in those couple of counties, we really serve a large area, but we're still a very rural hospital. And for us, we chose to become a critical access hospital, which limited us to no more than 25 acute care beds. That is more than sufficient for us. And as healthcare has moved from the inpatient to the outpatient setting, we just did a renovation of our place along the lines of that rural exemplar transition that I discussed before. We now have just 19 beds, and we use those for inpatient swing bed care and observation care. And it is very rare that we even fill that entire unit. 85% of our revenue, even as a hospital, comes in the outpatient emergency department setting.
Okay, so I think the black swan for the utilization of those beds would be the COVID outbreak, which has been it's been in the news for Missouri quite a bit. Has that impacted your particular medical center?
It surely has. And, what we have seen is that care networks have traditionally worked very efficiently, and a lot of larger hospitals, whether like Mosaic, they've decided to actually own a few rural hospitals and have a spoke approach in some ways to where services delivered within the system, or whether you have maybe a looser affiliation. What typically has been architected and understood is that those tertiary and quaternary care environments exist in urban areas or in larger hospitals. Those referrals from rural areas and smaller hospitals have been coveted and really worked for. What we've seen through various spikes in the COVID pandemic is that those larger quaternary tertiary care hospitals are really full. And even if they have beds available and rooms and spaces available, the demands on staffing of the level of acuity that goes into a COVID patient, and especially a COVID ICU patient, have hurt the availability to make those sorts of transfers from here. Well, then what happens? Well, we all work together as a system, and we figure out how are we going to ease the burden on the urban center or the larger center. How can we get patients out of those places and actually transitioned back to a place like Albany or a Mosaic hospital in Maryville or other smaller hospitals in the region? And it's brought about a level of system thinking and kind of an adaptive response to this black swan event. And we're seeing differences in patterns, differences in utilization The other thing that's happened is we worked as fast as we could to build new capabilities. We made the strategic decision in Albany years ago not to operate an intensive care unit. And so we have great services in what we do, but we don't have an ICU normally. Well, what have we done now? We've put together additional negative pressure capability. We've experimented with telehealth. We've figured out ways to start a hospitalist program and bring docs in who wouldn't have been here before, all in an attempt to use these assets in a different way as we all work together to respond to COVID.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
Let's do this, John. I want to try to paint a picture of what you can and can't do in your hospital. When you say you have 25 acute beds, that means you have 25 beds, period, right?
Yeah, that's what it means in our case. That wouldn't necessarily be true from a regulatory standpoint, but at this point, Bob, in my hospital, we actually operate 19 beds for acute care stays, swing bed stays, and observation. We have overflow capability. Of course, we're always planning for that next thing. So a surgery, prep and recovery area could be transformed. Emergency department beds can be used. There are things that we do to build surge capacity. But overall, the core functionality of my hospital is 19 beds.
Okay. So when we talk about trauma hospitals, there's, I guess, 4 different levels of trauma hospitals. And you guys are not a trauma hospital, I would assume.
We are not.
Okay. And now you do have an emergency room department, though.
Yeah, we operate an emergency department. We actually are blessed. We're not required to do this by law or regulation, but we have emergency department physicians sitting in-house 24 hours a day, 7 days a week. Oftentimes in rural areas or especially frontier areas, the emergency function of physician function is handled through an on-call arrangement. So the doc might be at home or wherever. In our case, we're afforded the luxury of having ER physicians in-house ready for whatever walks in the door. We have tremendous capability, not only in physician training and nursing training, but diagnostic technology, other partnerships and relationships that allow us to be a very effective front door to the healthcare system, regardless of what happens, because people in rural areas have heart attacks and strokes and accidents and all sorts of things, actually in higher percentages than in urban areas.
I would think that's the big challenge that I think most of us have. Until you need to go to a hospital here in Dallas, Fort Worth, where I reside, there are so many choices. How would I know where to go? And if I go to a rural area, how would I know that if I have a stroke, I could go to the Mosaic Medical Center to get treatment, or I shouldn't go there? That education process of making your community aware of what you can and can't do. I'm sure that if you want to have a baby, you just run and have a baby there, right?
So, Bob, it's good that you ask about that awareness and communication, because you're right. We can be difficult to navigate if folks aren't aware of our capabilities here. And one of the things that we love is that we tend to pleasantly surprise people with the level of capability in this hospital. As you suggested, most people don't go to the hospital until they really need to. When we recently went through the process to become certified as a level 3 stroke center in Albany, one of the things that was required for us to earn that designation was actually a public relations campaign. We helped people in our area recognize the signs of a stroke through the Be Fast indicators that you could look up online. We put up billboards indicating that we were a stroke center. We do drills with the emergency response teams from the area. And when somebody would call dispatch or an ambulance would go out, that's done through a rural district. So it's a one-stop shop for us. But they are very aware of our capabilities. They train with us. And then also included in that training and preparation is actually representation from the larger hospitals that would tend to receive our transfers after we did the front end of that emergency care. And so the neurologists, the emergency department physicians, in case of heart attack, the cardiology team, they're all very involved in the planning and communication. And it's a real system thought about how we would respond to those sorts of needs in a rural area.
Jon, that makes sense. If you have a lot of choices, you have a paradox of choice in a large metropolitan area. I could select a number of different hospitals, but if I'm in a rural area, I need to know more about that hospital and what they can do because I don't have a plethora of choices right there. And to that point, I'd like to kind of shift the conversation here a little bit. Out of all the hospitals in the United States, there's over 6,000 hospitals. I think about half of them are rural hospitals. And, when you live in a large metropolitan area, you don't care about what's going on in Albany, Missouri, or how they're taking care of people. But if you look at a map that shows the rural hospitals across the United States, it is a big, big concern. And if you don't have that type of quality treatment, you're in trouble. And we all know that the internet is becoming pervasive and people are moving out into the hinterland where they can have a lifestyle that they prefer. And a lot of these services might be able to be brought to them. So I want you to put on a new hat here. Recently, the Missouri Hospital Association has announced that you will be their next president and CEO. So big congratulations to you on that. That's outstanding.
Thank you.
And with that role, you're looking at a much broader patch of rural hospitals, over 100 or so there in Missouri alone. But let's look forward in terms of the needs of rural communities and healthcare reform. What are the types of things, Jon, that you think are missing? If you can elaborate on a couple of them and potentially what some solutions might be.
Sure. So one thing I have always said, and I actually stole this from my uncle, is that living in Albany, Missouri is a luxury. And I don't ever want anyone to think that this is a destination of last resort. It's actually quite the opposite. And you made mention of it, Bob. As technology enables people to work from wherever they wish, I actually project that a number of people will choose to move to an area like this. And I think that creates tremendous opportunities for rural communities to market themselves and to have folks understand what a luxury it is to live and work in a place like this. And I think it creates an incredible need for rural health to tell its story. Now, in my role as Missouri Hospital Association president, rural is a significant concern. It is coupled with the fact that we have incredible research universities, large urban hospitals, safety net hospitals, so many others. And I'm thrilled to be working for and with all of them. And what's great about it is there's incredible esprit de corps among the hospitals in the state of Missouri. And we really, truly are all working together to architect systems. And I think that leads to the answer to your question. How do we all work together to deploy our expertise and our technology to guarantee folks a standard and level of care and availability of care so that they can go live in a luxurious small town somewhere? And so we see incentives in place all the time toward rural broadband access and the infrastructure, roads and bridges and those sorts of things that make access to care a little easier and access to life a little bit easier in rural areas. 20% of Americans live in rural areas. They're raising the food. They're doing a lot of things that actually add to our national security and our way of life as a nation and a world. And so it's good for America for there to be a bunch of people in rural areas living well and producing. And it becomes a significant policy issue. And that's why folks are willing to make investments in rural broadband and technology and those sorts of things is it's actually an important part of the larger picture. So what you see now is people who have tremendous capability and a true mission to serve, figuring out how to use telehealth technologies, virtual intensive care units, virtual emergency departments, home monitoring, wearable technology, all these things that you talk about all the time on your podcast, Bob, because you are always thinking about what's coming next. The applications of those technologies toward increased quality and availability of health and wellness and health care in rural areas, it really can't be overstated. And we've had fun experimenting with those things in Albany. I was amazed. I walked in here 11 years ago and was thrilled to find out that we already offered teledermatology. And, it's hard to get an appointment with a dermatologist, but people at the University of Missouri and Columbia were setting aside part of their schedule to see patients via Polycom technology in 2010. And folks in Albany, Missouri could walk in here and get a dermatology appointment in very little wait time. And it was super high quality. And we've built on that over the last decade and will continue to do so.
Yes, for sure. Innovation does not have borders.
You are correct.
Today on the news, we have a lot of really horrific news. And if the house isn't on fire with a baby in it, it doesn't get on the news. But I think in a small community, when you become intimately integrated, some of these little stories surface and the community knows about it. Share with me a case in point where the exceptional attention to a person was given through a small community hospital. I know there's many of them.
Oh gosh, that's fun to sit and think about. We have earned a number of fans over the years, and sometimes they're folks who were skeptics, and maybe that's what's the most fun. We have folks who perhaps live in this community, but have the sense that, well, gosh, how good could it be? It's in Albany. And then that emergency happens, and almost out of a sense of necessity or even desperation, they enter our healthcare system. We have a partnership with Mayo Clinic. We're part of the Mayo Clinic Care Network here in Albany. And we have a number of folks who believed in the past that if they really wanted great care, they should drive to Rochester, 6 hours away, and engage there. And to be able to offer them that level of consultation and specialty care via shared access to an electronic medical record and expedited access to a team of subspecialists, the best in the world, through an arrangement and affiliation here. That's been a lot of fun. Of course, I won't give you names and details. I can't quite do that. But there was one particular gentleman who had been a bit of a critic of ours and unfortunately suffered a stroke on a holiday and came here and was very pleased to experience a board-certified emergency physician who could start treatment. Our CT scanner was warmed up and ready to go. We got a great image. We were able to figure out that it was a blockage, not a bleed, and therefore TPA was appropriate. We were able to start that medication here on Christmas morning and then transfer that patient to the patient's destination of choice, where they received follow-up care and assurance from their care team in that facility that everything that had been done here was perfect. And for that person then to come back 2 days later, having fully recovered from the symptoms of that stroke, possibly because of the care we delivered here, and bring cookies to the staff was a really great moment for everybody.
So, John, that TPA, we know that's a type of treatment. It's an acronym for a very long medical term. But if you do have a blockage, you can create a great solution immediately for a stroke. If you have a bleed, the last thing you want to do is give TPA because that'll exacerbate the bleed as opposed to loosening up the blockage. So,
absolutely. That's
a great story. Tell me the story about somebody that needed help and they showed up and you guys went to their house and did something for them. You told that story once before. You don't know what I'm talking about.
I do. We had somebody who was interested actually in receiving the COVID vaccine early this year when we were just starting to roll it out to high-risk population. And we had called that person trying to help them schedule an opportunity to receive that vaccine. And what they said to us was, I'd be happy to come and do that, but if it snows, I'm not going to be able to get out of my driveway. And our maintenance crew at the hospital heard that story. We knew the patient. We understood where that patient lived. And sure enough, it did snow. And our maintenance crew, without being asked or directed, went to the patient's house and scooped all the snow out of the front of their driveway to make sure they were able to get to their appointment to receive the COVID vaccine earlier this year. So, yeah, perhaps we can do a level of personalized care here that is difficult to deliver in other areas.
That fits into the definition of extraordinary primary care to the nth degree.
It was good.
Okay, well, this has been a pleasure having Jon Doolittle on the Business of Healthcare podcast. Jon is the outgoing president of Mosaic Medical Center and the incoming president and CEO of the Missouri Hospital Association. Jon, thank you so much for sharing your time and your expertise with us today.
That's my pleasure, Bob. I love your work, and I'm glad to be part of it.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.